very kind, giving kind introduction. So let me share my screen. Sir, my screen is visible, no? Adarsh, sir?
Yes, you can go ahead. Wait.
Yeah. Thank you. Thank you. As Adarsh sir said, septic shock is a major healthcare burden to all of us, all the critical care, intensivists, nurses, everyone. Every day we see around, in any ICU, we see around 2 to 3 patients in a 10-bedded ICU with septic shock. So it's a part and parcel of our life. So managing septic shock appropriately with appropriate time will improve patient outcomes and decrease morbidity and mortality. As sir said, nurses play a very important role. In fact, they are the face of whenever the patient we receive. The outcome of the patient depends on the nursing care and how we go about even the familial care, further post-recovery care. All of this depends on the nursing care only. So,
Dr. Ved, one moment.
Yes.
They're mentioning that your screen is not visible. You have to share the PPT.
1 minute, sir.
Sorry, everyone. 1 moment.
Now, sir?
Hope it's visible. Those who are out live. Yeah. Okay. Okay, Dr. Ved, go ahead.
Yeah. Okay. Okay. So we'll go about approach to manage and septic shock in in next 45 minutes. Then we'll take questions in further 10 to 15 minutes. So our objectives of the class, it would be to describe the clinical features. Post this class, you would be able to describe the clinical features of sepsis in the critically ill patient, identify the core principles of resuscitation and hemodynamic support of the septic patient, explain the importance of identification and control of source of infection. So these would be our objectives. And we'll discuss the topic in these subheadings. We will discuss definition, risk factors, how to recognize sepsis and septic shock, what are the scores available, what are bundles, how do we resuscitate and what is the golden hour, what are the hemodynamic monitoring tools and what are the investigations we do, when to start antimicrobial agent and which antimicrobial agent, and how to take cultures, what is source control, what fluids we have to give, what vasopressors, corticosteroids and other adjunctive therapies. So let's go. So for sepsis, all over the world, we have a association by name Surviving Sepsis Campaign. These, because we know due to the research and innovations being done in the field of sepsis and septic shock, over the past 3 decades, these are a consensus of experts who sit around every 4 to 5 years and discuss on the recent advances, practices all over the world and give us various guidelines regarding the sepsis and septic shock according to the innovation practices. So before 2016, there were different concepts of systemic inflammatory response syndrome, sepsis, severe sepsis, and septic shock. But this has been changed post 2016. So we'll briefly go about severe sepsis, septic shock, and SIRS. But these concepts are not being used, but still some of the countries practice still systemic inflammatory response syndrome. Only for a brief amount of time we'll go. And coming to guidelines, I will not go deeply into it, but we'll have a touch on it and we'll concentrate mostly on the basics in this class. So what is systematic inflammatory response syndrome? It was a constellation of 4 criteria. Whether patient is having temperature or hypothermia less than 36 or hypothermia of greater than 38 degrees centigrade, heart rate greater than 90 per minute, WBC counts greater than 12,000 or less than 4,000, and respiratory rate of greater than 40 or PSUOT of less than 32. So what they said is any 2 of these 4 criteria, we classify this patient as severe systematic inflammatory response syndrome. But what was the problem with SIRS? It lacks sensitivity. It can be positive in any case. It is less specific too. It cannot describe the severity of the disease and it may distract from searching for the cause of the infection. So because of these reasons, the 2016 consensus on sepsis guidelines by Surviving Sepsis Guidelines, they gave a new definition. Severe sepsis was completely removed from the spectrum, and a new screening tool was introduced by name QSOFA, which we'll discuss further slides. So current status, what is the things you have to remember? There are only three terminologies: infection, sepsis, and septic shock. As we know, infection is an invasion of a sterile environment by microorganisms. And what is sepsis and septic shock? Sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. Whenever a body responds to an infection, there will be a release of pro and anti-inflammatory cytokines and other inflammatory markers. Due to the pathophysiological involvement and physiological response of the human body, there will be interaction between the cytokines, and which will lead to further pathophysiology of various inflammatory markers, which lead to some immunological host response, which is defined as sepsis. And what is septic shock? It is nothing but sepsis with refractory hypotension. That means the patient is having circular or cellular or metabolic dysfunction. Even after proper resuscitation, or patient is requiring vasopressors to maintain mean arterial pressure of 65 millimeter of mercury, or his serum lactate is greater than 2 millimoles per liter. So it is a dysfunction when the patient is having sepsis with circulatory dysfunction of mean arterial pressure greater than 65. Despite fluid resuscitation and is requiring vasopressors, it is known as septic shock. So this variant will have mortality of 40%. So our aim is to prevent the patient with sepsis. Whenever he comes to our ICU, we have to treat him appropriately, recognize the patient, treat him appropriately, preventing the septic shock and further morbidity and mortality. So how to do that, we'll discuss further. So what are the risk factors for patients who admit to ICU? Like previous history of intensive care admission, presence of bacteremia, history of any positive GNP cultures, advanced age and comorbidities, immunosuppressions like patient having CKD, chronic liver disease, cancer on immunosuppressive therapy, diabetes and obesity, metabolic syndrome, cancer, community acquired pneumonia, previous hospitalization, and genetic factors. All these are the risk factors for sepsis. Whoever admit to intensive care admission, these can be a risk factors for further aggravation of sepsis. So whenever a patient with sepsis comes to our ICU, what signs and symptoms you have to see? So whenever you, when a patient with a suspicion of sepsis wheels into your ICU, what are the various features you have to see? These patients may have fever of greater than 38.3 degrees centigrade or hypothermia of less than 36. The patients may have heart rate greater than 90 beats per minute. They might be tachypneic. That means respiratory might be greater than rate can be greater than 24 per minute. There can be a significant edema. There can be an hyperglycemia of greater than 140 milligram per deciliter. The patient, when you do investigations, there can be leukocytosis or leukopenia. That means greater than 12,000 WBC count or less than 4,000. And there might be raised CRP, procalcitonin, and hemodynamics. Patient will have systolic blood pressure less than 90 and mean arterial pressure less than 70. And organ dysfunction signs, like patient may have altered mentation, respiratory index like PBF might be less than 300. Patient might be having oliguria, like urinary output will be less than 0.5 ml per kg per hour. And patient may have different hematological parameters like INR would be greater than 1.5, platelet might be less than 1 lakh, and he might also have ileus. And tissue perfusion we'll discuss later. Patient might have high lactates, delayed capillary refill time, and mottling skin. So how do you recognize the patients in sepsis and septic shock? What are the prediction scores available? There are many prediction scores available, but the most common prediction score, sequential organ failure assessment score, is being used all over. What is this score? It uses different, it is an assessment score which uses simple measures for different organ systems and grades accordingly from 0 to 4. And what they say, greater than 2 of SOFA score, it indicates severe sepsis, and it also indicates with every 2 increase in the SOFA score, the mortality increases by 10 to 20%. So, for example, if the score is 15, the patient might have a 90% mortality. But there are issues with it also. We'll discuss it further. But what is SOFA score and what we measure? We measure P/F ratio in respiration, We measure platelets in coagulation. We measure bilirubin levels in the hepatic system. We measure mean arterial pressure in cardiovascular system, Glasgow-Coma scale in CNS, and creatinine in the renal as a renal parameter. We grade accordingly from 0 to 4 and give them the final score. But it involves a lot of laboratory investigations. Hence, it is a cumbersome procedure. Hence, they came out with QSOFA. What is QSOFA? It is a simplified score in which in patient with suspected infection who have prolonged ICU can be promptly identified at the bedside. It has 3 components with respiratory rate of greater than 22, altered sensorium, and systolic BP of less than 100 millimeter of mercury. So among these 3 components, if a presence of at least 2 of these criteria strongly predicts likelihood of poor outcome in ICU patients with clinical suspicion of sepsis. But what are the problems with QSOFA? Most of the patients may not have this above mentioned criteria. Hence, they can be missed on evaluation. For example, patient might have pain abdomen, burning micturition, and suspected urinary tract infection. Can be missed by using QSOFA because they may not be tachypneic, they may not be having altered sensorium. And even neutropenic patients who has fever, oliguria, and an indwelling catheter can also be missed using QSOFA as a screening tool. Hence, they came to a conclusion that QSOFA is more specific than less sensitive. That means you can rule out, but definitely presence or absence of QSOFA definitely cannot be more specific than in identification of infection-induced organ dysfunction. So when to use QSOFA and SOFA? So whenever the patients who are coming from the community and who are not in ICU, QSOFA can be similar to a SOFA score. That means when you are in ICU, you are able to do all the investigations. QSOFA can be similar to a SOFA score, but the SOFA score is helpful in identifying septic patients with both in and out of ICU, but it involves many lab tests and hence time consuming. That's the reason why we can use QSOFA, but as discussed, it is less specific than, it is more specific and it is less sensitive. So always you have to remember that along with the QSOFA, you have to use clinical criteria, physiological criteria, microbiological criteria, and radiological criteria, and whole of your clinical acumen, and to suspect sepsis and further follow-up. So this is only a prediction tool, that's it, but it shouldn't be a definitive tool. So further, when you monitor the patient, resuscitate the patient, following up of the patient is more important than only this score itself. So coming to how do you go about a patient who comes to a suspected infection? So whenever patient comes to you, you have to do a QSOFA score as we discussed. And whenever there is a QSOFA is greater than 2, you have to assess for evidence of organ dysfunction. You will shift this patient to ICU. And whenever this you measure all the investigations, if the SOFA score is greater than 2, you will classify this patient as sepsis, and you will adequately resuscitate the patient. And even after resuscitation with fluids, if his vasopressors are required to maintain BP of greater than 65 and lactate levels are still more than 2, you will define this patient as a septic shock. So this is how you go about. But anytime if you are not having QSOFA and SOFA greater than 2, as we discussed, it is less sensitive, but still you suspect the patient is having some sepsis, you have to monitor the clinical condition and reevaluate for possible sepsis continuously. So whenever you are feeling that if your QSOFA is less than 2 or patient is having no organ dysfunction, even you are feeling that his patient is having some infection, you have to monitor continuously. You have to monitor his lactates, physiological variables for fevers and other clinical parameters. Anytime if you feel like sepsis, then you have to again monitor the QSOFA and SOFA. If they are fitting in, then you have to classify this patient as sepsis and septic. So coming to bundles, what are bundles? Bundles are the, as we know, bundles are collective evidence-based practices, which are simple measures which we apply at the bedside, which when they applied collectively at the correct time, evidence-based practices, they will definitely improve the outcome of the patients in morbidity and mortality. So in septic shock, with the course of innovations and research, the bundle recommendations have changed from 24-hour management to 6-hour to 3-hour. And finally, in 2018, the surviving sepsis guidelines came up with 1 hour bundle. In 1 hour bundle, what they say is to measure the lactate levels at the baseline and follow up with resuscitation. And they say to obtain blood cultures before administering antibiotics and administer broad spectrum antibiotics as early as possible. And they say to begin rapid administration of fluid 30 ml per kg crystallite for hypotension or lactate greater than 4 millimoles per liter, and to apply vasopressors if patient is hypotensive during or after fluid resuscitation to maintain a mean arterial pressure of 65 millimeter of mercury. So these are the 5 things, evidence-based practice statements which they are told to do in 1 hour bundle. So this is the most important thing you have to remember whenever patient comes to septic shock. Make sure these things are done so that it will improve the outcome of the patients. Then what is golden hour? You know, sepsis is a medical emergency, and if it is treated appropriately, you will definitely improve the outcome of the patient. So what they did, what they told, so you can see in this graph, whenever the patient has been treated appropriately with effective antibiotic therapy after sending appropriate cultures, you can see if it is given within 1 hour, you can see as less morbidity less than or mortality less than 10%. But as you prolong the treatment, if you are delaying the treatment further more than 1 hour, you can see the mortality can increase up to 100%. So so this is the most important thing. And you being the face of ICU, whenever you receive a patient, you have to make sure you send the cultures and antibiotics as early as possible. It plays a pivotal role in improving the outcome of the patient. So coming to initial resuscitation, how will you go about in the treating the patient whenever you receive a patient? So, so sepsis and septic shock are medical emergencies, and they recommend to treatment and resuscitation to begin immediately. So for patients with sepsis-induced hypoperfusion, they suggest to start at least 30 ml per kg of IV crystallite solution within first 3 hours of resuscitation. And they suggest to use dynamic measures over static measures. And we will discuss this in further slides. What are dynamics, what are static, we'll discuss in further slides. And they say for patients with sepsis or septic shock to who are being resuscitated, to use lactate levels for resuscitation. That means they have to follow the lactate levels, and decreasing serum lactate levels in these patients will show that the hypoperfusion is improving. And for adults with septic shock, they also suggested capillary refill time to guide resuscitation as an adjunct in resource limited settings. All these things will go up in further slides. Here comes the first MCQ. MCQs will be discussed by Adarsh sir.
So this is the first multiple choice question. So now you understood that sepsis with septic shock is a medical emergency. Yeah, so when you see a patient who is in sepsis, septic shock, wherein you need a IV fluid resuscitation, so it is mentioned in the guidelines that 30 ml per hour of IV fluid has to be given, which is a crystalloid, and it should be given over how much time? So you can drop your answers in the chat box. We will take 30 seconds for this. So I can see most of them are answering 3 hours. Okay. Looks like all of them are alert and listening to your class. Good. Okay. Dr. Ved, continue.
Thank you. So what are the hemodynamic monitoring? So after the resuscitation, how would you monitor your patient? So there are many basic hemodynamic monitorings. You can use your clinical examination of the patient, like monitoring the sensorium of the patient, heart rate of the patient, respiratory rate of the patient, urine output of the patient. So all these things come in the clinical examination. You can monitor temperature monitoring. You can use capillary refill time. You can use thin mottling score. You can use improved pulse oximetry or saturation measurement. You can use non-invasive blood pressure. You can use ECG monitoring, and you can use serum lactates. So these are the basic hemodynamic monitoring which you can use at the bedside at a basic level in your ICU. So what is capillary refill time? So capillary refill time is a simple bedside test which you use at the patient's bedside, which is an indicator of tissue hypoperfusion. What we do in this test, you know that you will press the nail bed for a few seconds until it turns pale, and you will release it, and you will wait for the return of the color in the same nail bed. So what they say is, if the color retains to the normal in about less than 3 seconds, you can tell the patient has adequate perfusion. But if it is taking more than 3 seconds, that patient is still hypoperfused. So this is a simple bedside test to detect hypoperfusion. It is basically used in remote resource limited settings whenever you don't have any other monitoring, but it is a definitive, and even it was being advised by the surviving sepsis, you can use this surviving capillary refill time as a monitoring for in resource limited settings. And what is mottling? Mottling is a skin discoloration around D, which we can see in small subset of septic patients. And when you grade it accordingly, as severe as the score increases, this tells the severity. Like score 0, there will be no mottling. 1, it will be a small mottling around the center of the knee. In score 2, it does not extend beyond the superior border of the kneecap. In score 3, you will see that the mottling area does not extend beyond the mid thigh. In score 4, it will not extend beyond the groin fold, and score 5, extremely severe mottling, you can see the mottling extending beyond the groin fold. So according to the severity, you can tell how severe hypoperfusion is. So this is one more score you can use in assessing hypoperfusion. And why you measure lactate in septic shock patient. So whenever there is a sepsis patient with elevated lactate, it is an indicator of tissue hypoperfusion or anaerobic metabolism going on. And it is an independent predictor of mortality in sepsis. So lactate clearance is associated with better outcomes. When you properly resuscitate a patient and your lactates are coming down in a septic shock patient, it indicates you are properly resuscitating, and somehow your lactates are coming down and some tissue perfusion is being going on. So definitely during resuscitation, lactate should be interpreted considering the clinical context and other causes of elevated lactate. Many like other confounders can also have elevated lactate, but definitely you should consider those confounders and take the lactate as a primary monitoring measure in a resuscitation of the septic shock patients. And what they said, as we discussed, surviving sepsis guidelines, they said using capillary refill time to guide resuscitation as an adjunct to other measures of hypoperfusion. What are the fluids which we can give? First line, they said crystalloids, and they said balanced crystalloids like plasmolite and Renal lactate instead of normal saline. And they also said albumin can be used in patients who receive large volume of crystalloids. Starches and gelatins are not at all recommended. And they said restrictive versus liberative fluid strategy after there is still insufficient evidence. So you have to go with the patient's clinical criteria, basic bedside measures like ultrasound, which we like point of care ultrasound, which is out of scope of this class. But there is no liberal fluid or definitive endpoint to it. They say 30 ml per kg within 3 hours, but you have to see whether the patient is having worsening of fluid strategy, and accordingly you have to categorize your patients with adequate fluid requirements. So next question.
So the next MCQ. So can you answer this? The crystalloid of choice during initial fluid resuscitation in sepsis will take 30 seconds. Answer in the chat box. I could see few answers equivocally saying that albumin versus balanced crystalloids. So again, I would request Dr. Ved, please emphasize on the type of IV fluids that we need to give in during fluid resuscitation. So albumin is definitely not a correct answer. So it's always IV crystalloids, balanced crystalloids.
Balanced crystalloids are always the preferred fluids because they prevent certain side effects like hypochloremia, acute kidney injury, and coagulation derangements. But they say albumin in patients who have large volumes of crystalloids, you have given some 6 liters of fluid, you can supplement with albumin, but definitely albumin is not a first line fluid which you give in septic shock patients. So you have to remember balanced crystalloids, you have to remember are the first type choice of fluids in the ICU. That's it. Albumin always comes after a certain point of the time where the patient's being overloaded. Even then, albumin can be given in only certain indications, but always the first line of choice would be balanced crystalloids. Okay, sir?
Yeah.
Okay. Then coming to mean arterial pressure. So it is recommended to maintain an initial mean arterial pressure of 65 millimeter of mercury. At least mean arterial pressure of 65. And they say mean arterial pressure more than 65 in higher mean arterial pressure, there was lack of advantage given the maintenance of mean arterial pressure of maintaining more than 65. The target of 65 millimeter is enough to maintain adequate perfusion. That's what the guidelines say. And they say the patients with sepsis and septic shock who require ICU admission to shift the patient within 6 hours because from the ER, because with certain studies showed when you prolong the ICU shifting beyond 6 hours, the morbidity increases. So whenever you shift the patient within 6 hours and give appropriate care, the outcomes have been better. That's what the guidelines say. So you have to remember that the patient, whenever he comes to ER, try to shift the patient within 6 hours to your ICU as early as possible.
So the next question. So what's the recommended initial target of mean arterial pressure in patients who are in septic shock? What is the number you have to chase? So most of them are answering correctly. Good. It's 65 mm of mercury. Okay. Okay. Coming to next question. So for patients with sepsis and septic shock, delayed admission from emergency to ICU increases mortality. So in that case, what would be the optimal time for admitting the patient from emergency to ICU? Is it 6 hours, 24 hours, 48 hours, 72 hours? So options you have is 6, 10, 12, 24. Yeah. So the guideline says definitely it is 6 hours and before. That patient should be inside the ICU. Okay, good. Dr. Ved, carry on.
So coming to what are the resuscitation tools which are available to assess volume status and tissue appropriation? As we discussed, there are basic hemodynamic tools and static parameters which we have discussed till now, but they say dynamic measures to use fluid resuscitation over physical examination like systolic stroke volume variation, pulse pressure variation, echocardiography, response to passive leg rise or a fluid bolus. So these all come in the advanced hemodynamic monitoring, which is out of scope of this class. So you have to just remember the dynamic measures are more useful than the static measures to guide fluid resuscitation. So, and also they said when there is no advanced hemodynamic monitoring, alternative level measures of organ perfusion may be used to evaluate the effectiveness and safety of volume administration, like temperature of the extremities, skin mottling, capillary refill time has been validated and shown to produce reproducible signs of tissue perfusion as we discussed before. Coming to vasopressors, what type of vasopressor you will start, how much dose you will start, and what adjuvant vasopressors you give. So they, norepinephrine is the first line agent over the other vasopressors. For adults with septic shock, starting vasopressors peripherally to restore mean arterial pressure rather than delaying infusion until a central venous access. So whenever patient comes, you should start the noradrenaline to the peripheral line. You should not postpone until the central line is placed. Once the central line is placed, you can change over to the central line, but don't wait for the central line to be placed. And norepinephrine with inadequate mean arterial pressures, like you have started norepinephrine of 0.25 to 0.5 microgram per kg minute, but still your mean arterial levels are not more than 65. You can use vasopressin instead of escalating the dose of norepinephrine. And in Also in patients, despite norepinephrine and vasopressin, you can add epinephrine also. So these are the things for vasopressors. Norepinephrine will be the first, and when you are escalating the dose of norepinephrine, start vasopressin. Even then it's not improving, you can start epinephrine also. So this is the same thing which we have discussed before. They say norepinephrine as a first line vasopressor, target a mean arterial pressure of 65. Consider invasive monitoring arterial blood pressure as early as possible. Place an arterial line for monitoring and lactate level monitoring also. Consider initiating vasopressors peripherally until the central axis is not available. Once the central axis is available, consider shifting the noradrenaline and adding vasopressin to the noradrenaline once the noradrenaline dose reaches the 0.5 microgram per kg per minute, and consider adding epinephrine in once it is not maintaining on norepinephrine and vasopressin. And they said consider adding dobutamine in patients with cardiac dysfunction if the hypoperfusion is present despite adequate volume status and blood pressure. So cardiac dysfunction is one state in which you consider adding dobutamine. Coming to antibiotics. For patients with septic shock, antibiotics are recommended to start within 1 hour of recognition. And they say whenever there is an adult patient with a sepsis or septic shock, rapid assessment of the likelihood of infectious versus non-infectious cause should be done. Like a non-infectious can be a pancreatitis, it can be a venous thromboembolism, it can be a CNS hemorrhage, it can be a stroke. So all these things, arterial thrombosis, all these things have to be ruled out if you have a suspicion of some non-infectious things. But if you are still suspicious, so rapid investigation has to be done as early as possible. And if you are still having a suspicion of sepsis in this patient, you have to start the antibiotics within 3 hours. And as you know, initiating antibiotics play a key role. When you are having a suspicion of sepsis, you have to start antibiotics within 3 hours as early as possible, they say. But if you are feeling like there is some infectious cause, try to rapidly investigate the cause, but still you are having a suspicion, start within 3 hours after sending appropriate blood cultures. But for adults with low likelihood of infection and without shock, they suggest differing antimicrobials while continuously to closely monitor the patient. So this is the same thing. When there is a definite sepsis, you feel that patient is having sepsis, definitely start the antibiotics within 1 hour after sending the blood cultures. And if the sepsis, you are feeling that there is some non-infectious cause and there is some shock, you have to administer immediately after rapid investigative measures within 1 hour. But if the shock is absent, you have to, as we discussed, we have to rapidly assess for the non-infectious causes. But still, if you feel that patient is having fever, tachycardia, oliguria, or some clinical signs of sepsis, you have to administer antimicrobials within 3 hours if the concern for infection persists. Okay. So next question.
Yeah, please answer this question. So now the patient is in potential septic shock. So what is the time to initiation of antibiotics? Is it 3 hours, 6 hours, 9 hours, 1 hour? Yeah, so that is a golden hour. Early resuscitation includes everything, including giving antibiotics. So you have to understand that please don't wait for the cultures to go and then give antibiotics. Okay. So early antibiotics is the key. Okay, good.
So as sir said, sending cultures is always better before the antibiotics, and you know how to take cultures. You have to properly prepare the patient, antiseptic precautions to send 2 pairs, one aerobic, one anaerobic culture, take around 10 ml in each bottle, and send the initiate the antibiotics after sending cultures. But if you are having any logistic problems in sending cultures, don't wait for the initiation of the antibiotics. It should be started as early as possible. Yeah. Coming to various antimicrobial terms which we use: empirical therapy, targeted therapy, broad spectrum therapy, multi-drug therapy, and combination therapy. So empirical therapy is when there is a suspicion in a patient of septic shock and there is an absence of definitive microbiological pathogen, you start some antibiotic. It is called empirical therapy. What is targeted therapy? In this therapy, the antimicrobials or antibiotics are given, are targeted to a specific pathogen. It is usually after once your blood culture is positive, you give a definitive or targeted therapy. And coming to broad spectrum empirical therapy, broad spectrum therapy. Broad spectrum therapy is nothing but giving more different antimicrobial agents with a specific intent of broadening the range of potential pathogens, like you give gram-negative coverage, gram-positive coverage, and antifungal coverage. So this comes under broad spectrum therapy. What is multi-drug therapy and combination therapy? It is a combination therapy is a comes under multi-drug therapy only when you give multiple antimicrobials to deliver empirical broad spectrum therapy to accelerate the pathogen clearance. Like you are giving for one organism 2 different antimicrobials so that pathogen clearance is better. This is known as multi-drug therapy. What is combinant therapy? This is nothing but you are giving different antibiotics of different classes. Like for gram-negative coverage, you are giving a piperacillin tazobactam and an aminoglycoside. Then it is called as combination therapy. It is a part of multi-drug therapy. So these are the different antimicrobial terms which can be asked in the exam. You just have to remember these things.
So considering the administration of types of antibiotics, this is the next MCQ. So when you are giving empirical antibiotics, so what is the optimal antibiotic therapy and how does it depend on? Is it depends on local prevalence of resistance organisms or patient risk factors, severity of illness, or is it all of the above? Yeah, most of them are choosing all of the above. So it's always like together. Okay, you have to look in a globally, like how is the resistance pattern at your institute? What are the patient risk factors and what kind of resistance organism do you suspect? How severe the patient illness is? So altogether, you have to initiate the optimal antibiotic therapy empirically. Okay. So when it comes to targeted phase, once the causative organism is identified and susceptibility is also given. So if you are giving double negative, double cover for a gram-negative organism, so when is that indicated? If there is a proven infection or colonization with antibiotic resistance organisms in the last 1 year, or is it the local prevalence of antibiotic resistance organism? Is it the broad spectrum antibiotic usage in preceding 90 days, concurrent use of selective digestive decontamination, or all of the above? There are only a couple of answers for this question. Take an extra minute and read the question, please.
So in targeted phase, as we discussed, we give double gram-negative cover to enhance the pathogen clearance. So when it is given, like if a patient is having proven infection or colonization, if the patient has been admitted in your ICU in the preceding 1 year and he had an antibiotic resistance pattern to multiple antimicrobials before, so in that you will use, or there is some local prevalence of antibiotic resistance organism, or there is broad spectrum antibiotic use in preceding 90 days, and there is some selective digestive decontamination. So all these things, they would have used definitely multiple antimicrobials before, whenever the patient is admitted in the ICU. So enhance, also you will definitely suspect some type of resistance pattern in these patients whenever they get into the ICU. So in these patients, you give multiple antimicrobials. So whenever you have these patients having these antibiotic resistant antimicrobials, history of broad spectrum antibiotics, history of proven infection or colonization with antibiotic resistance, or concurrent use of selective digestive decontamination, you have to target with double gram-negative cover. That's what this question is about. Little difficult to understand, but sorry, I would have kept a simple question. Yeah. Okay, sir.
Yeah. Okay.
Thank you. So although the same thing, they suggested using 2 antimicrobials with high risk of MDR, like the same thing in the previous question which we discussed. The patient has been admitted in the ICU, was using home dialysis, was using some immunocompromised drugs, have received multiple antimicrobials in the past 90 days, history of some what do you say, history of some drug abuse, CLD, CKD, these are prone for MDR organisms. So they suggest using 2 antimicrobials with gram-negative coverage for empiric treatment over 1 gram-negative agent. And for patients with low risk of MDR organisms, like the various complications which we discussed before are not there, then you suggest using against using 2 gram-negative. Then you can use only single gram-negative agent. And once and also they suggest once your positive pathogen is known after the blood culture have come, they suggested against using double gram-negative coverage. They say once the your resistance and microorganisms have been found out, you have to taper them antimicrobial cover to as single coverage as possible to de-escalate from double gram-negative cover to the single cover once the organism is found out. Okay. So coming to procalcitonin. For adults with sepsis or septic shock, they suggested against using procalcitonin plus clinical evaluation to decide when to start antimicrobials as compared to clinical evaluation alone. So procalcitonin should not be used as a criterion to start an antibiotics, but measurement of procalcitonin can be used to support the de-escalation of antimicrobial therapy. That's what they told about procalcitonin. Coming to source control. So whenever you receive a patient with sepsis and septic shock, like example, you receive a patient with cellulitis, you receive a patient with cholecystitis, you receive a patient with some sinusitis, which you feel like which can be a source of infection. Effective source control should be done as early as possible. Like the patient is having some central line device, which is he has been hemodialyzed from the outside, which can be a source of infection. The suspicion of infection, you have to remove the source control as early as possible. So that they say the source control should be done as early as 12 hours, so that effective antimicrobial therapy and appropriate source control management can be done. This is what they told about source control. Next question.
So this question is related to the current discussion. So what is the time frame for implementing source control? So within what period of time that the source control should be addressed? Is it within 12 to 24 hours, within 6 to 12, 9 to 12, 24 to 48? I know the 12 is the magic number here, but okay, if you say 6 to 12, you say 12 to 6, most of them are answering 6 to 12.
Yeah.
Okay, now that they understood, now that they understood as early as possible, like 12 hours and before. Okay, good.
So coming to steroids, whenever your patient is not responding to volume resuscitation and vasopressor therapy, if you are not able to maintain his BP even with noradrenaline and vasopressin, they suggest adding hydrocortisone 200 mg per 24 hours in divided doses or 100 mg bolus followed by continuous infusion at 10 mg per hour. If the patient is improving from the vasopressors and your septic shock is improving, they also say to wean the steroid slowly as the patient improves from the septic shock. There is no association with vitamin C and reduced mortality. The recent papers have clearly shown that IV immunoglobulins are not recommended. Red cell and product transfusion, they say restrictive transfusion strategy and red blood transfusion after the hypoperfusion resolved, and they say to maintain hemoglobin more than 7 grams per deciliter. And FFP not to be used to correct laboratory clotting parameters unless there is an absence of bleeding or planned invasive procedure. Coming to glycemic control, so they say to avoid hyperglycemia, like the patient should not be having sugars more than 180 milligram per deciliter or hypoglycemia. or there should not be wide swings on blood glucose levels. The target blood glucose should be around 140 to 180 milligram per deciliter. If two consecutive blood glucose levels are greater than 180 milligram per deciliter, start insulin therapy, and blood glucose have to be monitored every 1 to 2 hours until stable and once it becomes stable, you have to measure every 4 hours thereafter. Coming to ARDS, and acute respiratory distress syndrome is a pulmonary manifestation of multi-system dysfunction. You will diagnose it when you have impaired oxygenation in the form of PBF of less than 200, bilateral pulmonary infiltrates on chest X-ray. There should be an acute insert, and it should occur after a precipitating event. So, what ventilation you use is you can use NIV and versus invasive ventilation. But initial stages of ARDS, you can there is some insufficient evidence regarding NIV, but if the patient is worsening, you have to take him on invasive ventilation as early as possible. They suggested intermittent neuromuscular blocking agents over infusions, boluses over infusions, and a low tidal volume ventilation strategy with limitation of plateau pressures to less than 30 centimeters of water, and proning should be used for refractory hypoxemia more than 12 hours per day. So, nursing management plays a very important role in proning of the patients. We have seen during the COVID pandemic, so how many patients, multiple proning sections may go on till months also, and how nursing care helps in proning, like preventing removal of the ET tubes, maintaining vascular catheters, preventing neurovascular injuries, preventing sores, wet sores, proper respiratory care, and the proper muscle protection. All these things, so all these things to prevent abdominal, how to keep proper beddings or cushions to prevent increased intra-abdominal pressure, preventing urogenital injuries. All these things are to be very important in maintaining of proning. And nurses are the core, nurses play a core or pivotal role in management of the patients on proning, like head change over every 2 hours. So proning is like a very basic, after at least of a COVID pandemic, proning becomes a part and parcel for every ARDS patient, and you should be very well through in knowing about the complications, indications, and of the proning procedure which we do. We also tried awake proning in most of the patients during COVID, but a patient who is having refractory hypoxemia, who is being prone for 20 hours, 16 to 20 hours, you have to be very careful in these patients. And they also told to consider BV ECMO and refractory hypoxemia caused by sepsis-induced ARDS. Coming to renal replacement therapy, they suggested using either continuous or intermittent renal replacement therapy. And with no definitive indications for renal replacement therapy, they suggest against using renal replacement therapy. So they suggest only for definitive indications like acidosis, hyperkalemia, pulmonary edema, anuria, or raised creatinine or uremia. Until unless these are not there, don't use renal replacement therapy. What is the indication for blood purification? There is insufficient evidence to make a recommendation on the use of blood purification techniques. They are suggesting against using polymyxin deep hemoperfusion. Coming to sepsis nursing quality care indicators. What are these? International Critical Care Society of Nurses, after the 2017 guidelines, they prepared a task force and given certain indicators for better quality control and improving the patient outcome in these patients. So what are these? We'll go one by one. So, so they say time to perform blood culture sampling is an important nurse quality indicator. So they say the proportion of sepsis in which blood cultures are sent within which cultures have been sent as early within 1 hour, and patients have to be in patients whom the cultures are definitely sent before antimicrobial culture is an important nurse quality indicator. And like it's a sampling, like all the patients, if you take some 100 patients, you started 100 patients with antibiotics. So in 100 patients, if you have given blood culture, you have taken blood culture in all these patients, then your quality indicator will improve. And timing of blood culture, as we discussed, starting antimicrobial within 1 hour and remove the culture as early as possible also can be a nurse quality indicator. And time to start antimicrobial therapy. They say proportion of cases in which antibiotic therapy was started within 30 minutes after prescription is also an important quality indicator. And time to reach fluid bolus, as we discussed, fluid bolus within 30 minutes after prescription and 30 ml per kg of crystalloid fluid should be given within first 3 hours. These two also an important quality indicators. And time to perform lactate monitoring, like patients in which lactate level was drawn within 30 minutes of prescription is an important quality indicator. And maintaining glucose levels like 140 to 180 milligram per deciliter is also an important quality indicator. And family care conference to address goals of care. So this is an important goal of care which has been also added in the 2021 guidelines. So patients should receive family care conference to address goal of care within 72 hours of ICU admission is also an important quality indicator. So total sepsis bundle performance, they will use the compliance of all these things and measure the quality, nursing quality. So all these indicators helps in improving the treatment, maintenance of the bundle and improving the outcome of the patients. So this comes your last MCQ.
So one last question to you all. So could you answer this? So which of the following statements are false? In sepsis, septic shock, insulin therapy is indicated when a glucose level is more than 180 milligrams per deciliter. In sepsis with septic shock, enteral nutrition within 72 hours is indicated. In sepsis with septic shock, unfractionated heparin is preferred over low molecular weight heparin for thromboprophylaxis. In sepsis with septic shock, discussing goals of care with family and prognostication should be done at the earliest. Which one do you think is false? Yeah. So most of them are correct. They're answering saying that there is no difference between unfractionated heparin versus low molecular weight heparin for DVT prophylaxis. So as we know that glucose is indicated 2 consecutive values of more than 180, there is an indication to administer insulin therapy and early enteral nutrition as early as possible. And as you rightly said, there is no difference between unfractionated heparin versus low molecular heparin for DVT prophylaxis. Yes, family-centered care should be always be practiced, and early prognostication should also be done. So, yeah, moving forward, Dr. Ved, please continue.
Yeah, thank you. So summary, the keys to successful approach are timely identification of sepsis and septic shock, early resuscitative treatment, appropriate and timely antimicrobial therapy, and whenever possible, direct infectious source control should be done. Multidisciplinary approaches is often required for optimal management, and a good communication system between clinicians and patient family is essential. Thank you.
So hope it was very informative and insightful to you all. Dr. Vedaghosh has presented comprehensively, but in a simplest way to you all. Hope you could take positive information from here, because whatever the information that you read, listen, watch, it has to be always translated into your clinical practice. That's when a good nurse role is important. Yeah. So now that we have understood that whatever you do in a patient with sepsis, septic shock, it is early the better. Like as we said, the golden hour. So initially it was 12 hours, 6 hours, 3 hours. Now it has come down to 1 hour. So whatever you do, the best possible treatment has to be done in the first 1 hour, like giving appropriate fluids, vasopressors, sending cultures, administering antibiotics, measuring lactates, urine outputs, all these things, and family-centered care. Because as I said, the nurse plays a pivotal role in administering the therapies, whatever the doctors order. Okay, and you play an important role, a bridge between doctor and the patient as well. So this is a very crucial and important topic, sepsis and septic shock. In a daily basis, we keep managing around the clock. So for the exam purpose and as a practice purpose also. So hope we had an informative session for 1 hour. And if there are any questions, you are free to drop in the chat box.
Or they can unmute themselves, can ask us, I think, so now. If
Yeah, you can unmute yourself and please feel free to ask. Most of them are messaging saying that, thank you, sir, good, informative, comprehensive. Okay. You're taking it positively. Thank you so much. Thank you, everyone. And we have come to the end of the session. If we don't have any more questions, we can wind up. One minute more. Looks like most of them are logging out, Dr. Ved. You can,
okay. Thank you, sir.
Stop
Thank
it and
you.
leave the meeting. Thank you, Dr. Ved.
Thank you very much. Thank you, sir.
Yeah. Thank you all. Bye.